Good morning, everyone. I am Dr. Sendil Nathan, working as reader in the Department of Conservative Dentistry and Endodontics, Adi Parashakti Dental College and Hospitals. Today's topic is on Ingle's method of working length determination. Following the completion of adequate coronal access and canal exploration, the most critical act in ensuring success of endodontic therapy is the accurate determination of the working length before you go for radicular preparation. So what is working length? Working length is defined as the distance from a coronal reference point to the point at which canal preparation and the obturation should terminate. This is regarding definition of a working length. Coming to the significance of working length determination. It determines how far into the canal the instruments should be placed and work to remove tissue, debris, and metabolic end products. It limits the depth to which the canal filling may be placed. If calculated correctly, it increases the probability of success of the treatment, and conversely, it may lead to the failure. It may affect the degree of pain and discomfort the patient will feel during following appointments. So, when you go for a working length, coronal reference point plays a major role in the successful outcome of your procedure. So, what is a coronal reference point? It is a site on the occlusal or incisor surface from which working length measurements are made. This point is used throughout the biomechanical preparation and obturation. So, what do you understand by this? You should not change the coronal reference point. It should be maintained uniformly throughout the procedure till you complete your obturation. Changing a coronal reference point might lead to a change in working length, which in turn lead to overextended obturation or obturation which is short of the apex. Before deciding the coronal reference point, we should remove all the defects and the caries. We should remove all unsupported cusp. We should remove the old restorations, and we should establish a straight line access. And if there is any need for occlusal direction, which enhances the patient comfort, we should go for it. These things will ensure the reference point will be unchanged throughout the procedure. The reference point can be the cusp tip of the canal being measured, or the same cusp tip for all the canals. In the case of anteriors, incisal edge can be taken as reference point. If the file is deflected away from a particular cusp tip, the cavo surface margin of the particular cusp may also be used as coronal reference point. If no particular definable point can be located, a ledge can be made in the tooth structure that can act as a reference point. Intracoronal reference point should not be used so as to prevent the movement of the stopper during the measurement. So the most common methods for measuring the working length or marking the coronal reference point is with silicon stops. These stops are special tear shape or marked rubber stops. These are you can see it in the pictures. These are silicon stops which are used to mark the coronal reference point. It is critical that stop attachments be perpendicular, not oblique to the shaft of the instrument. Always the stopper should be straight and perpendicular. It should not be drifted or oblique to the instrument, which will lead to wrong working length determination or loss of the coronal reference point. Always develop the habit of looking directly at the rubber stop where it meets the reference point on the tooth. The next important landmark or anatomy in root canal treatment is apical foramen or apical 1/3, you can say. So what is anatomical apex? What is anatomic apex? It is a tip or the end of the root determined morphologically. This is called anatomic apex. Next comes radiographic apex. It is a tip or end of the root which you see radiographically or determined radiographically. This is a difference between anatomic apex and radiographic apex. Root morphology and radiographic distortion may cause the location of radiographic apex to vary from the anatomic apex. So these things we have to keep in mind while we are determining the working length. Next comes apical constriction, which is otherwise called minor apical diameter. So what is minor diameter or apical constriction? It is the apical portion of the root canal which is having narrowest of diameters. You can see it in the slide, in the pictures. So it is the portion of the root which has canal which has narrowest diameter. It is usually will be placed 0.5 mm to 1 mm short of the apical foramen. The position of minor diameter might be 0.5 mm to 1 mm short of apical foramen. The minor diameter widens apically to the foramen, which is called major diameter, and it assumes a funnel shape. So this is the difference between, this is regarding minor diameter and the major diameter. The minor diameter is apical constriction. It is a place up to which you can clean up shape and can do a obturation. Beyond this, the root canal filling or instrumentation should not go. Next thing is cemento-dentinal junction, that is CDJ. So what is CDJ? Cemento-dentinal junction is the region where the dentin and cementum are united, where the dentin and the cementum meet. This is the point at which the cemental surface terminates at or near the apex of the tooth. Historically, the CDJ landmark cannot be located. Either whether it is clinically or radiographically, you can't locate the CDJ landmark. So where it actually lies? The location of CDJ ranges from 0.5 mm to 3 mm short of the anatomic apex. You all know that apical constriction is located 0.5 mm to 1 mm short of the anatomic apex. So this is regarding location of CDG. So the location can range from 0.5 mm to 3 mm short of anatomic apex. So where you stop your observation? Butler concluded that root canal should be filled as far as 0.5 mm from the apical foramen. You should not violate the apical constriction. The apical diameter should be kept as narrow as possible. If it is violated, then there might be chance of overextension of your obturating material, or the debris might be extruded into the periapical region, which in turn can cause flare-ups. So what are the different methods of working length determination? It is ideally classified into radiographic methods and non-radiographic method. Under radiographic method, there is Best method, Bregman's method, Raman's method, Grossman's method, Ingle's method, Butler's method, X-ray grid system, seroradiography, and digital radiography, direct digital radiography. In non-radiographic method, we use tactile method or tactile sensation, apical periodontal sensitivity, taper points, or electronic apex locators. So here we are going to discuss about Ingle's radiographic method. First, you have to measure the length of the tooth in a preoperative radiograph. This will give an rough idea about your working length. So from this, you are subtracting about 1 mm, which is for safety allowance. You all know there might be some distortion in image or magnification. So in order to negotiate this, you are subtracting about 1 mm from the measured preoperative measurement. So then you set the instrument at this tentative working length. And when you take a radiograph, you just measure the difference between the end of the instrument and the end of the root. Add this difference to the original measured length. If the instrument through some oversight has extended beyond the apex, subtract the difference. From this adjusted length of the tooth, subtract about 1 mm for safety factor to confirm the instrument within the apical termination of the root canal at the CDJ. We all discussed about the placement location of your CDJ and minor diameter. So in order to achieve the safety factor, you subtract or decrease about 1 mm from the length to achieve the location within the apical termination of root canal. Then you set the endodontic ruler at this new corrected length and readjust the stop on the exploring instrument. A confirmatory radiograph of the new adjusted working length is highly desirable because of the possibility of radiographic distortion, sharply curving roots, and operator measuring errors. So we just have to always keep in mind, go for a confirmatory radiograph to ensure the working length, the file which is used for working length is not going beyond the apex or it's not short of the radiographic apex. And again, you will face an extra challenges like curved roots, which will be difficult to manage if you lose your working length. And there are possibilities of a perforation or ledge if you don't spot the curved roots at the beginning of your procedure. So to conclude, no one method of working length determination that can be used with 100% accuracy. For success, the clinician should use rational thought in combining tactile sense, radiographic, and electronic devices to arrive at the desired apical terminus of endodontic preparation. So the use, it's not that this radiographic method will be success, will give you 100% success. So you can always use an electronic apex locator in combination with your radiograph to achieve 100% accuracy in working length determination. That's it for today. Thank you.